Oh, I love your work. Okay. Sorry. You can see me coming around the roundabout in Montana City. I was on 2 wheels. The back end is like spinning. I'm like, safety. Get there. So I apologize for being. Okay, let us start with prayer because I need it today. Okay. In the name of the Father, Son, and Holy Spirit. Amen. Getting here safely. Getting my son to the bus on time. Thank you for this day. Just be with us today. Walk with us, help us do this well, learn things well. And we pray for anyone who's sick and suffering, lonely, discouraged, was often forgotten. Pray for all our care nurses out there doing good work. Give them courage and strength and wisdom to care for whoever's in front of them as they know how. Amen. Okay, so what is happening today? We're gonna do a quick little review on electrolyte. But then we're gonna jump into fluid status. Just goes hand in hand, right? So what do we call this? This is less than 8.2 milligrams per deciliter. Anything come to mind? Awesome, what do we call that? Good job.
Yes.
I probably was supposed to go the other way and say like, what is hypocalcemia? You're like, I don't know, anything less than 8.2. Okay. Let's try this, shall we? Hypomagnesemia. Well, less than one.
1.5.
Yeah, 1.5. It says 1.6, but I remember 5 better than 6s, so that's 1.5 is awesome. Hyperkalemia. Greater than 5.1, 5.3, or 5.5. Good. Okay. What other kinds of things would we see with hyperkalemia? So arrhythmias. What's a little kind of tingling in our fingers, paresthesias, and muscle cramp weakness. That doesn't help us, right? Okay. What do we do for hyperkalemia? KX-late, we try that first if they're able to swallow and we have time. If they're actually in an arrhythmia and we need to get them out of that quickly, insulin and glucose. So funny, those are opposite acting things, but we give them together and it pushes that potassium out of the bloodstream into the cells for a short amount of time. You know, maybe it buys us an hour or so. Okay, awesome. What about hypokalemia? What do we, potassium supplements, food supplements. Have you ever seen potassium in a pill form? It isn't like that big. And like shots. I just bet this comes all the way down like a little burning potassium. Or we can put it in liquid with juice. Also kind of nasty, probably. Yes, I think it is. From the people's faces. That's what I'm picking up on nonverbals. Okay, so we try that. If not, we need to do it a little bit faster. Through a central line, good job. Slow, through an IV piggyback. Okay, what's it called when we have sodium greater than 145? Hypernatremia, awesome. What can we do to help these folks? Give them hypotonic solutions. Hydrate, they're able to drink water, good. Are we gonna give them a salt shaker? No, it would be on low sodium diets, awesome. We just talked about this one. Anything else we should say? What would be the value? Yeah, less than 3.5? That's what I heard, less than 3.5. Good, okay, and yeah, that's what it's called. I mean, what's the value? Less than 135, okay, that's hyponatremia. What can we do for them? Hypertonic, slow, give them the salt shaker. They wouldn't be on a low sodium diet. Even sodium chloride would be good, but sometimes we give hypertonic solution very slowly. One last little guy, maybe? What's this one? No, I don't know. This is Meg. Okay. All right, this is just my notes. Okay, awesome. All right, what about calcium? What would the level be for hypocalcemia? Awesome, less than 8.2. And what would you expect your phosphorus? High. Remember that inverse relationship. What do you think your mag might be? Yeah, so mag and calcium kind of go hand in hand. Phos and calcium work opposite of each other. So we can target those to bring them in balance. Yeah.
Is the insulin and glucose thing that we do for the arrhythmias, is that like a standing order or do you have to?
Oh, gosh, I think you would need, no, it's not a standard.
Okay.
Doesn't, well, depends on where you work. Yeah, it is not like an ACLS type thing. It is just like for that patient, the doctor would be putting in the order and you would be grabbing your insulin and your dextrose. Good question. Any other worries? So whatever the deficit is, we're either trying to do like oral replacement, unless it's severe, and then we have to go to IV. Usually it's things. Okay. Low calcium, we're gonna give calcium. Low potassium, we're gonna give potassium. All right. Okay. What's this? Do this. Let me just check that we are actually recording right now. Last. How many classes have we had together so far? What's happening there? Oh. Let me just check it. Okay. It's. Right there.
Yeah.
Is it too late? There we go. Oh my God. Okay, all right, let's talk IV fluid, shall we? So. We are gonna take a quiz, do not let me forget, 0830. Let's just talk about fluid status within the body. How is it, and how much do you put out per day on average? It wasn't up on the screen. Well, even if it is, you didn't tell me. Yeah, 2.5 liters or 2,500 mLs, right? It's essentially what we take in a day and essentially what we put out if everything is in working order. And depending upon what other factors, or like the I part, the intake part. And how much you're taking in. If you're taking in more than 2.5, than 2.5. You guys are all very good about having water bottles. Awesome. You're well hydrated, taking in all that intake. How else do we get it? Liquid, but also in food. And then, what's this metabolism business?
Isn't the water a byproduct of the photosynthesis?
Yeah. I'm just doing for this. I'm so happy right now, right? Or, yeah. Good job, good job. So that's all the intake portion of it. And then the output portion is, how do you lose fluid? What's the one that comes to mind most often? Urine, okay. How much is that accounted for? About 1,500 mLs? Okay, again, depending on intake. Feces, 100. And what's this breathing and skin? Insensible losses. So these are not things that are easily measured. You can't just like put a bag over someone's mouth and catch what they're breathing out with ventilation, you know, to account for that. But if someone's respiratory rate is 40 throughout your whole shift, you have to be thinking to yourself, wow, they have lost more than just what? This is giving us 400 mLs. So you have to take that into account for their overall fluid status. What about if they're breathing at a rate of 40? Hard to do for a long period of time, right? We'd be worried about that. But they're also drenched in sweat. So every time you go in, you're like, oh my gosh, I gotta change those sheets again. They are just drenched in sweat. Not easily quantifiable. You could put that on a scale. Do you remember what the? It's not a conversion, it's right. 1 kilo equals 1 liter fluid. So when we weigh people, they're up a kilo in a 24-hour period. We can say that they are up a liter. Okay, so if you were really on strict diets and those, they may have you weigh that if you have that little scale there. But otherwise, you have to account for these insensible losses. Not as easy to measure as maybe stool, like liquid stool and urine. Okay, so thinking about that when you're assessing your patients. All right, so regulatory mechanisms, we have the renal system, the endocrine system, and the respiratory system. That's awesome. It's one of my most favorite things, right? Okay, what is this thing?
No, Renin
Renin-angiotensin-aldosterone system. Did you learn this? Where?
far.
Everywhere? That's right, because it's so awesome. It's so awesome. If you ever thought, is there a God? You just have to look at this. We are like wonderfully made. Seriously. Our body is like trying to keep us in balance and has all these ways to try to do that. It's amazing. Okay, so you have learned this. So tell me, what is this? Let's say I have lost fluid. I have vomited. I have been in a car accident and I have lost blood volume. So when you check my blood pressure, it's like 88/52. What is my little rat system gonna try to do?
Bring it up.
Bring up my blood pressure so that my little noggy and my little heart get blood, which in turn means oxygen, which in turn means life, right? So thank you, body. But how does it do that? It's identified. Where is this drop in pressure identified? Seems like the kidneys, because that's what's going to release the renin. But first,
Right.
For baroreceptors, we got chemoreceptors, we got baroreceptors. Baro is all about pressure within the system. Chemoreceptors are actually like the chemical composition, like when we talk about ABGs here soon. That's what they're picking up on. Isn't that awesome? We have this little thing being like, oh, well, we got low pressure here. Where is that sitting? Right in the aortic arch and their carotid sinuses. So right in the blood vessels, right? Being like, we're kind of low. We're low on pressure here. What's happening? So then our beautiful kidneys kick out renin. Right. Well done. Then what? Liver produces angiotensinogen,
Oh,
right? That combines with renin. And then
angiotensin one. It's me.
by our lungs kicking in. Yeah, angiotensin 1 is made when those two, the liver and the kidneys, renin, angiotensinogen, angiotensin 1. And then we have this sweet little thing coming from our lungs, boom, to make angiotensin 2, which is a potent, I love it, potent vasoconstrictor. What does that mean? It squeezes down on those vessels. So when it squeezes, that then in turn increases blood pressure. That's a beautiful thing, right? What else is happening? So we got the blood vessels constricting. So if they're all dilated, pressure's low. You need constriction happening in the arteries, arterioles. Oh, clamp down. Okay, we give medications to do that when our body isn't working well. But thankfully, our body does this. And then what else? Not only are we like affecting the squeeze, we're going to
Increase water, sodium and water reuptake.
yes,
Kidneys.
awesome, because that increases volume. So we're hitting it by two accounts, volume and squeeze, muscle tone, not muscle tone. Well, it is all muscles that squeeze down the arteries and volume itself. So aldosterone and antidiuretic hormone are helping us do that. So we're hitting volume and the squeeze to bring up that blood pressure, right? So how does that affect output? It could be decreased when we're all like low blood pressure because your kidneys are not getting good perfusion. So you will see a decrease in urine output. What is the value that I want you to be paying attention to when you're checking like hourly outputs? And that would be like, okay, first hour, they had about 40 mLs out. Next time I go in there, they're like at 32. Next hour, they're at 25. Next hour, they're at 20. I'm like, what's happening here? But especially after here, I'm contacting the provider. Like, kidneys, something's happening here. I don't know if it's volume related. I don't know if it's blood pressure related. I don't know if it's perfusion related. I don't know. But I pick up on it here, not 12 hours later, seeing like too late. Contact them here so that we can help out our little system by maybe giving what? I have low volume. The RAS system has done what it can. My low urine output is kind of still not so good. What can I give in a rapid fashion to help bring up pressure? Fluids. What kind of fluids? Yeah, isotonic fluids. Such as 0% NaCl, which is normal saline, good, or lactated rich. Either one is fine. They would order it by saying, please administer a 500 ml bolus IV times 1 now. So you go into your little pump. You're gonna hit rate. For my people who were in lab yesterday, was the highest rate we can give on a regular pump. 999. And what is that value? 999 what? Milliliters per hour, right? And my volume to be infused. So we can go 500, I'm paying a liter bag, because they're probably gonna say, do another one. Their blood pressure doesn't respond. Okay? That makes sense, so all of this is tied together. All of this. And just for fun, think back to farm days. Is there a medication that affects this system to help bring blood pressure down? This isn't really related to volume status. ACE inhibitors, that's what it stands for. ACE stands for what? Angiotensin converting enzyme. So what does a ACE inhibitor do? It inhibits that. So there is no potent vasoconstrictor. We're not getting angiotensin 2 formed. You don't have that constriction because they don't need it. If you're hypertensive, you already are constricted. Your blood pressure is too high. We don't want that. So we're going to give you a medication, not allow that. So fun. NCLEX question related to that. What's a common side effect of ACE? It can be an effect, like the therapeutic effect, low blood pressure, right? Which we want, but not too low. Sure, that can be an effect of the med. Yeah, this cough. You were talking to someone and you're taking an admission and they're like, you're like, oh, what about that cough? Is it productive? How long have you had it? When did it start? Have you been around anyone sick? If the answers are like, no, I've had it for a long time. It's just a stray cough that never produces anything. You go to their medication list and you look for an ACE inhibitor. And you're like, oh, you change that. Some people have no idea. It will just be coughing for like weeks and weeks. Not know that it is a very common side effect. Sometimes they stay out of it, but mostly we can switch them. So. Okay. You know, you remember that? ACE, we know affects something coming from the lungs, right? So the A, C, E, from the lung, right? All things, people help us remember these little things. Okay, good job. So indicators of fluid status. So basically, physical assessment is where we start, but then we have these different diagnostics that we can do as well. So, body weight, I just told you, we weigh people on a daily basis to check weight. It's actually the best indicator of fluid status. Rather than our calculated I's and O's, sometimes we miss things or, you know, don't get all the output or there's insensible losses or hard to quantify. So really the most accurate way of checking fluid status is their weight. So tell me, get a daily weight out on a beach. You cannot stand. Okay, is that what you're thinking? So when you learned weights, it was an assessment, right? And all you could hop on the scale. Yeah, that's not usually US. Well, sometimes I guess they can wheel in the little, okay. They do have standing scales. Let's say your patient doesn't stand.
Maybe like Elkhorn, if they couldn't stand, they would keep them in their wheelchair. And like wheel them up onto the thing and just subtract the weight of the wheelchair.
Yeah, that's awesome. Yeah, so you'd have to get the wheelchair weight at some point. And then just subtract it from that weight. That's awesome. What if they're in bed?
Sometimes hospitals have the bed weights.
Yeah, most hospital beds have a little button that you can push. But what's an important factor when you are weighing someone consistently on a daily basis? Yes.
Weigh them first thing.
Weigh them first thing in the morning, right, to get before they like urinate, whatever's happening, so first thing. Before you get them admitted, I'm sorry, go ahead.
I was gonna say like wearing the same things and the same heats, like whatever you do on the first time. Exactly.
Yes, so that should be like documented in some way, or that it's just understood. When a patient is first admitted, we always have a fitted sheet, a draw sheet, Chuck's pad, blanket, and top sheet, one pillow. Okay, so then you have to zero it before they get in the bed. Get them in the bed and then press wait. And it will give you it in kilos usually or 2 pounds, but. Okay, so then the next day, after you brought in 3 blankets and they have 3 pillows on their bed and they have their favorite pajamas on, you're gonna have to get it back to what you did at the very beginning. Okay, really important, really important. All right, awesome. Body weight, osmolality, tell me about that. People in lab yesterday. Osmolality.
It's the millimoles per kilogram.
Right, so millimoles being solutes, so it's number of solutes per kilogram. Good job. Milliosmoles per kilogram, so we're talking inside our body. Inside our body. What is normal serum osmolality? 275, 295. Good job, milliosmoles per kg. Okay, that's normal, that's important for us to know, especially when we talk about osmolarity of fluids that we're gonna get. Okay, tell me about BUN. How does that help us, and creatinine for fluid status? Checking the chemistry panel out. From here on out, you should do that with every patient. Just pull them up and be like, okay, how we do? What's my BUN and creatinine doing? That can tell us fluid status, electrolyte status, kidney status. You expect if they are dehydrated. Higher, lower. Higher, right? So your BUN will be high, your creatinine, remember that's really more indicative of how your glomerulus is functioning. So your BUN will be higher and your creatinine may still be within normal limits, but maybe a little bit higher, closer to that 1.2 mark. Well, let's say you are fluid overloaded. There's too much fluid in there. It might be low. Creatinine could be high depending upon kidney function, right? But BUN low. Urine specific gravity, tell me this. Specific gravity. You get this from this clean catch. From the values for that. I don't want to check it.
Is it like 1.00 to 1.03?
Job. Good job. I had a donut, I'd throw it up to you. Okay, 1.005 to 1.03, good job. So what does that mean? We're looking at that urine and let's just start here. What do you think it looks like when we're like at 1.035, 1.040? Is it gonna be dilute or is it gonna be concentrated? Yeah, remember, higher equals drier. So it can be concentrated looking, perhaps, Um. Maybe not foul smelling, but just like dark. Maybe sediment is visible in it. And we're not talking about infection, we're talking about concentration of solvent. Okay, so higher the drier. This. You're like 1.0000. And so this is when we're like, got a lot of volume coming out. This is when you have a little volume coming out. Concentrated, dilute. This can look like water. No yellow fluid at all. This can look like a cup of coffee. All right, awesome, all clues into fluids text. So tell me the physical assessment findings for volume deficit. Those are all diagnostics that we were talking about. What's your patient gonna look like, sound like?
We have dry.
Okay, so dry mucous membranes or fluid volume deficit. Awesome. Dylan, here's one. Yeah,
Really slow.
yeah, that's always the one. You're like, is it longer or less or longer or shorter? So let's just say longer. So when you check, you are checking here, not so good. Yeah, like my age or older. So here is a good place to check. Does it pop back? For babes. Click on their little. Where is it? I don't know. Oh. I have no idea.
Can I give it a top of the word?
Seems like you get one. I'll check. I'll get back to you on that one. Good job, Turner. Would be prolonged, right? So prolonged tension. Good. The buttons. They all like kind of wrinkled. They're really dehydrated. Or the things. Yeah,
They'll probably complain or
yeah, yeah. If they're able, right? Okay, little signs. What does someone heartbreak do when you're dehydrated? Because your blood pressure is down. It's a compensatory mechanism. That's another thing our little buddy is doing to like say, okay, if I don't have a lot of volume, I gotta increase my rate. Trying to keep that balance for perfusion. Awesome. Respiratory rate. Variable, I think, depending upon underlying condition. Temperature. Maybe slightly decreased. These might be your low grade people, like 99.2, 99.1. Yeah. Okay. Anything else?
There might be like neurological symptoms too, like it could be really irritable, it's slow. I
Yes.
forget what exactly it was.
Yeah. Right. Neural changes can have confusion, lethargy. Okay. Urine output. Decrease, specific gravity. Increase. BUN. Increase. Hematocrit and hemoglobin. Yeah, this one depends, right? Because if we've lost blood, then obviously it's going to be decreased, right? Yes, so what's it? Decrease. How about over here? Change of colors or a little excess, what do we got going on there? Oh, not too bad, all right,
Edema.
edema, okay. Have you all seen edema? Where you put your little finger in and just take it out, and the little indentation just stays there? Yeah, so it can be like up to like 4, right? That can be in our lower extremities or where else? People, every area of your body can be edematous, okay? Things that you don't think can be edematous can be edematous. I'm just saying. Well, okay, not here, but maybe here. Any dependent area, like if you're lying supine, it's all gonna be like, got you there, pitting edema on your back, on your butt, on your legs, on your arms, scrotums. For the love, you're like, what is happening? I didn't learn that in nursing school. You know what you do when you have like an edematous scrotum? You have to like take a little towel and like sling it up. It's crazy. It's crazy. So edema can be everywhere. 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 Okay, and severe, yeah. We are fluid volume overload. Where is that fluid when you're seeing that? Is it in the vascular space? No, it is in the interstitium. It's everywhere it shouldn't be. Right? Yeah, okay, so it can be very excessive. What do we call it when we actually have fluid inside of the abdominal cavity? Ascites. Awesome, good job, keep going.
Checking their veins system.
Yeah, positive JVD, good. So you're talking to your patient, they're lying back in bed and you just see like their JVDs are like, okay, and then you're checking their lower extremities, you're like, oh my gosh, 4+ pitting edema. Okay, what else might I hear or see?
Freckles.
Crackles, awesome, so your list is not awesome for them, but awesome for us, okay. Crackles. You can hear crackles all the way up, right? So be listening, identifying where they are. It can be throughout. Yeah. And then maybe a moist sounding cough, maybe not productive, but a moist sounding cough. Yeah. Okay. What does your pulse feel like? Bounding.
Oh.
So that means we have extra fluid in the vascular space when we have a bounding pulse. It's just like you barely have to touch it and you are feeling it. Like, whoa. Okay, you see that positive JVD? And you're hearing the crackles, you're like, oh my gosh, fluid volume excess, it's like screaming at you, right? What does their H&H look like in this picture? Decrease, it's not really that they've lost blood, it's just diluted. Because they have so much volume. It looks low, but it's not really low. It's because they have too much other fluid on board. Or it can be high if we've given a lot of blood. So this one is big. Does that make sense? If you've just had a trauma and we've given you 6 units of packed red blood cells, you're going to have a bounding pulse, you're going to be fluid volume excess, and your H&H is going to be up. But if we're looking at a CHF picture like we were describing of the pitting edema and the crackles throughout and the positive JVD, then it will look diluted. I will ask you those questions. And just as a side note, if you're every patient we should be thinking about these things, right? Do you need to have an order to tell you to be doing eyes and nose? Okay, that's not a well worded question. Do I want you thinking and assessing about fluid status, even if you do not have an order that says, I know? Yes, okay, so technically, to do eyes and nose, you do need an order. However, as astute RNs, just because you didn't have an order to do eyes and nose, would you just not care that their urine looked like my tea? And their mucous membrane or like lips were cracked? And their eyes are like all stickies because they're so dry? And they have prolonged turgor and their BUN is like 50? Like, no, because the doctor didn't order eyes and nose. Don't be foolish, right? Like, that's your job, is to assess. Whether they're telling you to write down the numbers or not, you are doing that. Because that is your assessment of this patient. Don't. Okay, so here we go, little question. A nurse is reviewing the lab results of a patient suspected of dehydration. Following values are noted. When I took this question, it gave you like, hi, oh, normal range. I took those out. You're welcome. Serum sodium is 150. High, low, or normal? High, good job. Potassium, 4.3. Normal, good. Hemoglobin 18. You see that little, can you see the note on the bottom there?
Nice.
Like, thank you. So I always think these ranges are kind of hard for me to remember. They're, you know, a little bit weird, 12, 16, 13, 17. Depending on if you're male or female, I just think 15. So that's my starting. Like, are we around 15? Are we higher than that or lower than that? Yeah, okay, so 18 is. And you know, this is a male or female type, and hematocrit is 55. Okay,
You can pull that tab on the bottom up to. That little line on the bottom, yeah, there you go. Yeah.
pull up.
Nice.
Thank you so much. Look, you can see it now. Okay, thank you so much. So normal is 35 to 50 for females, 41 to 53 for males. So it's 55 high. Okay, BUN of 30 and creatinine of 1.3. High. I want you to pay attention at 1.2. Yes. Okay, so given these lab values, what condition do you suspect? Acute renal failure? Fluid volume excess, fluid volume deficit, hyperkalemia. Which one can you get rid of right away? Hyperkalemia, because your potassium is just fine. So now you just are down to 3. Okay, so test taking strategies. Help yourself get to the right answer. Acute renal failure. What other information would you need? Yeah, urine output would be helpful, yeah, right? Are we less than 30 mLs per hour? Yeah, that'd be significant. My potassium would be high. If I'm in renal failure. Okay, so I'm not thinking that. So now it's between fluid volume excess and fluid volume deficit. Waiting. Deficit? Yeah. Yeah, how did you come to that decision? Kind of help push you to that. Sodium level high. Yeah. Your fluid volume overloaded, your sodium will be low. And then everything's high, H and H is high, UN is high, UN is high. Yeah. So, I'm sorry you are, it's so fun, just bring it all together. Okay, oh wait, don't look at the answer now. John, how do I bring it down? Okay, all right, a patient is diagnosed with fluid volume overload following IV fluid administration. Which of the following would the nurse expect to assess in this patient? Actually read the answers. Don't just pick what you saw. So sunken eyes and dry mucous membranes. You're like, nice try. Boop, no. Okay, hypotension and tachycardia. No. Decreased urine lethargy. Jugular vein distension and yeah. So, what's all the A, B, and C is? What? Indicative of. All right. A patient receiving an IV infusion of normal saline develops crackles in the lungs and increase in blood pressure. What should the nurse do first? Ooh, okay, discontinue the IV infusion immediately. Increase the IV infusion rate. Administer a diuretic as prescribed. Change the IV to a hypotonic solution. Okay, so this person has fluid volume overload. What are you going to do first? Which one can you get rid of right away?
Increase.
Increasing the IV infusion rate makes no sense, so get rid of that. What? Okay. Okay, raise your hand if you think A. Raise your hand if you think C. Some of us didn't vote, people, we want to be voters, okay. Change the IV to a hypotonic solution. Okay, all right. Okay. The answer is A. Okay, so discontinue the IV infusion immediately. That's gonna be your first action. And then you would go to the diuretic. Tell me about your thoughts for the hypotonic solution.
Cause it brings the fluid from the outside the cell to the inside the cell. So we thought it would like lower the blood pressure. I don't.
Get would for short term. But you would need an order for that, you know. And we need a little bit more information because really when we use hypotonic solution, we're really trying to rehydrate a dehydrated cell. But I love that you're thinking like it's kind of like our insulin and dextrose idea, like moving things temporarily. I love that idea. Okay, does that make sense? So we would just stop whatever's going in them first. Yeah, they're getting too much. Okay, so let us move to. We talked about osmolality, serum osmolality, 275 to 295. Awesome. Osmolarity is different in that we're not talking about inside the body. We're talking about when we're looking at an IV bag and you see written on there the osmolarity. And it will say milliosmoles per liter. And then tonicity. That's just the ability or capability of a solution to modify the volume of cells by altering their fluid content. We're talking about osmosis happening. Does this bag have that ability? Yes or no? Isotonic? No. Hypotonic and hypertonic? Yes. So let's look at this. This is from your PowerPoint, I think your book as well. So crystalloid solutions are our IV bags. We're not talking about blood, that's colloids. This is crystalloids. We can have hypotonic solutions. And they're going to have an osmolarity, see there, less than 270 milliosmoles per liter. Examples of that would be 0.25 normal saline. So what would you call that if you are giving a report? Usually you don't say they are receiving 0.25% normal saline. You would say a quarter normal saline. What about 0.45? Half normal saline. Okay, we're gonna talk about this in lab for my Thursday people, so you're okay. You're like, oh, I don't know what we're doing right now. D5W. Yeah, it's 5% dextrose in water. it is considered a hypotonic solution in the body. We'll talk more about that. So, as you guys were saying, what do hypotonic solutions do? Yeah, take fluid that is in the vascular space, perhaps, and move it into the cell. So it causes the cell to swell. I remember that because there's an O in hypo. And I just think of that little cell being like an O, swelling, hypotonic. Okay, so things we need to consider, hypotension may worsen. Why would that be?
Lowering the blood pressure.
Yeah, you're lowering the blood pressure by lowering what?
Blood volume.
The blood volume. Yeah, because I'm taking the fluid from the vascular space and moving it into these cells, so there's just less volume to circulate. The blood pressure is going to continue to drop. Can increase edema. That should say cellular edema. Right? Because our hope is we're taking it from like the interstitium and the vascular space and putting it into the cells. So we're talking about cellular edema. Okay? And then may cause hyponatremia. So that's what you would be watching for if you're given D5W and you're seeing someone's sodium slowly trending down and everybody's wondering why. Be like, because they've been on D5W for the last 2 days. Let's change that. Okay. All right, isotonic solutions, what happens with those? No fluid shift. So that's given to replenish fluids into the vascular space. Dehydration. Hypertonic solutions. We have a osmolarity greater than 300, so that's greater than our serum. So that's anything dextrose and saline combined. So D5 0.45% is D5 half, D5NS, or 3% normal saline. I have never given 5% normal saline. That is so hypertonic. Okay. What do we worry about with that? Yes, irritating the veins. Fluid overload, because where are we moving the fluid from?
So,
The cells into the vascular space. So then we can throw them into fluid overload. Can cause hypernatremia, because if you're given 5% sodium chloride, that's what you're giving them. You can cause high sodium and high chloride. Good job. Here's a little picture what that looks like. One question, and then we'll move into. A patient is receiving an IV infusion of LR. Which of the following conditions would most likely warrant the use of this fluid? Hypovolemia due to blood loss, metabolic acidosis, we haven't even learned that yet, so sorry about that. Severe dehydration due to diarrhea, and hypertension and peripheral edema. You're like, okay, I can get rid of metabolic acidosis because I don't even know what that is yet. Hypertension and peripheral edema. Would we be giving LR for that? No. Okay, so hypovolemia due to blood loss or severe dehydration due to diarrhea. Okay, raise your hand if you think A. And raise your hand if you think C. Okay, good job. It's actually A. But would it be wrong to do it for severe dehydration? No. But usually when we're talking about blood loss, we go to LR because it most closely resembles serum. More so than normal saline. They both will rehydrate. So that's kind of picky, but just know when we're talking about blood loss, LR. You're not wrong, but. Okay, a nurse is administering a hypertonic IV solution to a patient. Which of the following outcomes would indicate that the treatment is effective? Okay, so hypertonic. The patient's blood pressure drops. The patient has increased urine output. The patient experiences increased peripheral edema. The patient's sodium levels increase. Like, don't put this one on the test. I don't know. It is deep. Patient serum sodium, so when I was talking about that 5% sodium chloride. Yeah. Okay, awesome. Is that it? Oh no, one more. Okay, a nurse is preparing to administer IV fluids to a patient with hypernatremia and cellular dehydration. Which of the following solutions is hypotonic and would be most appropriate for this patient? 0.9 sodium chloride is saline, that's isotonic. Good, even Steven. 3% sodium chloride, hyper, lactated ringers, ISO, 0.45 sodium chloride. I vote. That's what you would want to give. Hypotonic solution. Thursday, people, don't worry, we are going to go through this tomorrow.
No. Oh, oh. Brother.
So. Let me open it up for you. I don't. I guess. Shall we say you can go, you are done? You can do it on Monday. But we have plenty of time. There's only 10 questions.
Yeah.
Go ahead and refresh. Let me just double check one sec, don't start yet. There.
Based
Okay, I just want to make sure I don't have the time limit on. Oh, I do. Oop. No, not in. Oh, okay. Okay, we're not helping each other, just do it on your own. Do it.